There we go. Can you all see that slide? Brilliant. Okay.
Yeah.
Right. So as I said, to start off with, it's over here now. So you're going to be watching down my left ear for the rest of the talk. As I said, just a short update of the respiratory viruses that are around, keeping track with what COVID's doing, because that's a thing that's of importance to a lot of people with aspergillosis who were amongst the first to be given the vaccines. But we're talking about 4 or 5 years ago now. So let's see how it's progressed. This chart represents the surveillance over the last 12 months of COVID, and you can see these are the numbers of cases detected, going up to 400, 600 at the top. And last year, in fact, this time last year, we were on about 200 cases, which rose, and we had the steady ups and downs throughout last year as we've becoming learning to expect. We got very used to this sort of pattern of sort of surge and famine in terms of the virus. But remember that before 2024, over this side of the graph, these peaks were up at several thousand in the worst part of 2020 and 2021. So these represent a big improvement. But as you can see now, since November, last November, this pattern has completely stopped. And all we've got is a steady rate of infection at around 100 cases per week, maybe less than that some weeks. So there's clearly, and as time goes on, even more clearly, been a change in this surge type profile of this virus. From the start, it surges because it can meet lots of vulnerable people and infect them and cause symptoms. And then as we gradually become resistant, then the surge dies down because there are fewer vulnerable people to infect until the next variant of the virus comes along, which can now infect all those people again, and the surge goes up. Can you hear that noise behind me? Not distracting. Okay, we'll leave the window open. It's a bit hot today. Typical of sort of been waiting for warm weather all year, and I complain once the sun comes out. Well, we have stopped. So what it's telling us is that there are very few newly vulnerable people. There's just the ongoing people who we know resistance to this virus fades after about 6 months, and so you've got an increased chance of being infected. So that's presumably these people, just steady rates of infection and no big boom or bust. So then it's telling us that the virus has run out of ideas, basically, and this is fading into the background now. So it's still around. We're still looking at 100 cases in a week, or is this a day? No, could be per day. Yeah, that's per day, isn't it? So it's still there, but this, of course, is UK-wide. So this is a very big population, and this is a tiny number of infections. So it looks like we're coming to the end of this boom and bust until the virus comes up with a new variant that can cause another surge. But it's beginning to look like it's run out of ideas, which is how the natural history of these things carries on. So hopefully we may have seen the end of the boom and the bust for a while. Other important viruses are flu, and this year we had a nice peak around sort of Christmas, and it's been tailing off ever since. So even flu, even though there's more around than background, than there will be in the summer, so it'll be coming down a bit more. We've passed the peak. There's less flu around. So you can, I wouldn't say you can drop your guard straight away, but if you've been vaccinated, you are less and less vulnerable to this infection. The same with the COVID infection as time goes on. So that's also good news. We await the next surge at the end of this year. This surge goes on most years and has done for decades. We don't seem to be seeing this happening so much with COVID. It tends to surge in the summer and autumn, which is a bit odd, but I'm sure we'll see people looking at the reasons for that reporting over the next few years. Other viruses, you've got your common cold rhinovirus, which is chugging along pretty much steady rate of about 10%. Flu is dropping, as we said before. This is a little bit more current, I think, than that earlier graph. It's still coming down quite fast. There's COVID. It's come right off the surge levels and has now stayed low for probably 6 months now. And RSV that we were worried about and everyone got vaccinated for towards the end of last year has also faded out to nothing. And of course, a lot of this fading, we've got a vaccine against influenza, a vaccine against COVID, and now a vaccine against RSV for elderly people are probably helping drive these numbers down. So it's all looking good as it was for the last few months, which is great. So we don't think you need to be too worried about these viruses now. They're until next time. COVID may yet surge in the summer, but it's not. It's looking increasingly less likely. So we'll see. Okay, so that's that little bit of public information news. And on to the main event, which is something we're calling training your immune system. Now, this is something I've been kind of dimly aware of when we all get interested in vaccinations. I was aware that some vaccinations were called training immunity type of vaccines. So I wanted to discover why what mechanism this new type was. And this is my efforts to do so. To generate immunity, you can train your immune system or you can vaccinate for your immune system. And the difference between training and vaccination mainly lies in how and why the immune system is being prepared to fight off infections. There are two different mechanisms and two different ways that we can use to help you fight off infections. And of course, we're talking about bacterial infections and viral infections, chest infections that people with CPA and ABPA get a lot and people with asthma get a lot. So if we can reduce the numbers of those infections, it will be of great benefit to this population of patients and of course lots of others. Vaccination. We're very familiar with vaccinations now. Vaccinations is a targeted way to train your immune system and fight a specific disease without making you too sick in the process. Of course, if you had the actual disease, it would make you very sick, but a vaccine is disabled in some way to produce the immunity, but without making you ill. Usually done in one of a few ways, introducing a harmless piece of the virus or bacteria that you're fighting. So it can be a protein or an inactivated form. What it doesn't mention here are the new types of vaccine that were developed for COVID, which were the mRNA vaccines, which are what is injected into your arm is a piece of RNA, a piece of messenger RNA, which is used by your body to produce proteins. So you're actually producing the antigen for your own body to react to, and that's how that's vaccinated. Now that carries a number of advantages, as we found out during COVID, because one was developed inside 9 months, which must have been a world record for as an effective vaccine as it was. So that was amazing. This triggers your immune system to make antibodies and memory cells. So the next time you get that infection, these antibodies are around, the memory cells are around, and you can fight off that infection quickly. And you would hopefully experience a few symptoms and certainly keep you well out of hospital, as was proven during COVID. Not everyone was able to do this, but I think it had the success rate in excess of 90%, I think it was, depending on the vaccination. So what was suggested to me when I read this article was that this is like a vaccination is like showing your immune system a wanted poster, like they do when they wanted a cowboy in the Wild West for committing a crime. Wanted of the virus, dead or alive. And your immune system now can recognize the enemy, and if it ever sees it, it will arrest it or hang it high or whatever. That's what a vaccination is. So what is training? Okay, again using an analogy, training is like your immune system going to the gym to get stronger overall. Okay, rather like this chap down here. He's got grey hair, he's a bit elderly, but he's gone to the gym and he's much stronger. And that's what can happen to your immune system if you can train it. Again, vaccination is like learning a self-defense move for a particular kind of attack. So you can block a kick, for example. But training is like you will become stronger overall. So all aspects of your body become stronger rather than just one part. One example, the slightly older of what people of us will know about. So this is me, probably not Lauren, but back in those days when you were a school child back in the 70s, you used to get the BCG vaccine. You got BCG? They still do it because they stopped doing it in the 80s, didn't they? Yeah. You're not that old. You're half my age, woman. BCG stood for Bacille Calmette Guerin, which is a live attenuated vaccine. So this was a strain of mycobacterium. It was designed to fight off TB, because back then TB was more of an issue than it is now, although we're getting back to it being more of an issue in modern times. And it was an alive strain of this bacterium, so your body was going to fight that quite robustly. If you inject a live bit of bacteria into your arm, your body will react very strongly to it and cause all this inflammation. And I imagine many of us will remember all the yellow green pus that used to come out of that inflammation, especially if somebody else in your school bumped into it purposefully or otherwise. You're exposing your body to a live amount of bacterium, but that bacterium is unable to cause you to become ill because it's been altered in some way, it's been weakened. So that's a good thing, obviously. That's one type of vaccine. It is mainly given to infants and children, like I've just described, where TB is more common. It used to be given to everybody in UK or at about age 12, at age 11, 12, something like that. But I believe it's discontinued now. We don't do it routinely in the UK now. It is only given to at-risk groups like healthcare workers or people from high incident region of TB. So people who've been on holiday abroad or come into this country to work or something like that. I do remember in the past, when I used to work in cancer research, that a research group actually tried BCG injections to fight off certain types of cancer. And they would literally treat a cancer patient with this vaccine, and they'd get about 10% reduction in the cancer because the inflammation caused their immune system to respond and to become more active, and it would fight off the cancer to a certain extent. It wasn't a cure, but it did help. And that's a long time ago. It's in the 1980s. We're very familiar with the COVID vaccine. The vaccines that we have we've used for COVID were vaccines that literally infected our own cells, caused our own immune system to react to our own proteins and produce these Y-shaped molecules, which are antibodies. And here's the virus in the middle. And all the antibodies that we produce when when you get an infection, are all there ready to attack the infection like this and remove the attacking virus, which worked very well. The BCG, on the other hand, is really interesting because effectively it trains and vaccinates at the same time. So it specifically protects against tuberculosis, just as I've described, and you can tell if you've been vaccinated against TB in this way because you will have, usually on your left arm, a little scar where this inflammation took place, a keloid scar. But also what happened when you had that BCG vaccination was an explanation of why it helped in cancer studies. It trains your immune system in a broader way, a concept known as trained immunity. Okay, so not specifically generating antibodies, but training the rest of your immune system to recognize and react. Okay, so I've just talked about that. Yes. Okay. So a broader immune boost, trained immunity. So here's where it gets interesting. So as an example of how your innate immune system responds to an infection, here's some skin. And the skin has a cut with blood coming out, and all these bacteria have been introduced into the cut. Inside your skin here we have a capillary blood vessel, which these are all the little red blood cells, but also in your blood are these white blood cells, in this case leukocytes, but these are examples of macrophages, and macrophages are things that attack and eat bacteria. So these can travel out of the blood capillaries by squeezing themselves through the cells that make up the wall of the capillary, can travel to the site of the cut, consume literally phagocyte, if that's the right word, something like that, and consume these bacteria, limiting the infection. And these cells often, while they're doing that, also die. So what you'll end up with in the cut is all that yellow goop that collects in an infected cut. That's all these things that have given their lives to save you from being infected by all the bacteria. And these leukocytes, similar things, are the things that you are training to respond. So when you get your BCG, these leukocytes were exposed to the vaccination, and it taught them to respond faster to infection. It taught them to release more cytokines, which are the things that activate the rest of your immune system. And it would not only kill one or two bacteria, it would kill a wide variety of bacteria, viruses, and even fungi, I'm sure. So something there's a mechanism that's able to make us more resistant to all kinds of infections rather than one kind of infection, as is what happens in vaccines. Obviously, how does this affect people with aspergillosis or pulmonary aspergillosis? We can't as yet vaccinate against aspergillosis itself. There are vaccines being developed for aspergillosis that I remember first hearing about in 2012, and they don't seem to have progressed to an actual vaccine yet. So we can't vaccinate you against aspergillosis, although they haven't given up. There are still research efforts going on to make that possible. But we can vaccinate you against all sorts of other infections that you're likely to get if you have pulmonary aspergillosis, the flu, the COVID, the pneumococcal vaccine we were talking about only the other day, shingles, tetanus, diphtheria, pertussis, RSV, Haemophilus. These are all vaccines against infection, and they're all very good at keeping you away from these different types of pathogens that make you ill and give you exacerbations if you've got severe asthma, aspergillosis, and all the rest of it. Despite all these, you will well know more than anybody else, aspergillosis patients still get lung infections. And you get lung infections via a variety of different types of infection. So it would be ideal if we could train your immune system to be stronger at fighting off those infections. We don't have to be specific, so we can use training to see if that works. And this company, set in Spain, seem to have made strides in achieving that. So the normal situation is that one of these pathogens, so they've got viruses, they've got bacteria, I don't think there's a fungus in there, get into your airways, cause an infection, and you take antibiotics to treat that infection. And you well know that that cycle can take weeks before you're feeling better again. So I think some people were only talking about that this morning or this afternoon. So it works, but it involves a couple of weeks feeling poorly at least, and sometimes can take some time to fully recover from. But what this company have done is they've taken a range of these pathogens, and the list is here: Staphylococcus, Streptococcus, Klebsiella, Haemophilus, Moraxella, all things that tend to be involved in airways infections, and they've killed them stone dead using heat, I should imagine. So they're now coloured grey because they're dead, and they've put it in a spray. And the spray is designed to go under your tongue. And what happens is your body starts to experience higher levels of protection against not only these pathogens, but also viruses and other types of pathogen. You don't need as many antibiotics, if any at all in some cases, and all you've done is drop or spray this liquid containing this dead bacteria under your tongue for a few days, maybe a week or two. So how does that possibly work? Well, in this paper, what they found was if you do that with young children, babies, you get 70% less lung infection. And if you do it in adults, it goes up to 80% protection against all types of infection, not just these caused by these pathogens, but all types of infection, which is really weird, but it demonstrates that this type of immunity is broad-based, and we'll talk a bit more about that. The study was conducted on real-life data in a hospital, not dissimilar to this one, and all they did was do a retrospective look at children and adults who had this spray. It's very harmless, just a spray that goes under your tongue, so it's very low risk of danger. So they could give that to a lot of different people, and then went back and looked at how many of them needed antibiotics later in the year, and how many had exacerbations and infections. And they found that this product, MV130, confers protection against respiratory infections by both specific and non-specific mechanisms, so by both similar to the vaccine and also similar to training your immune system. Many of the infections that were measured as being reduced by this treatment were virus. So it's not just about putting some dead virus in this spray. There was no dead virus in the spray, but the half a dozen pathogens that went into it were enough to strengthen the immune systems of these people, and they were able to better resist viral infection as well as bacterial infection. This has been demonstrated in experimental infections and in a clinical setting, in particular in young children where a viral origin is prevalent. The people that received this treatment had all kinds of different reasons why they had lung infection. It wasn't asthma, it wasn't COPD, but it was all different types of things like if you got the flu and you had a follow-on with an infection, then this treatment seemed to help those people avoid getting that secondary infection. This is a vaccine based on trained immunity, and it depends on the activation and memory of the innate immune system, not the adaptive immune system. So it was about training those macrophages to attack the infection rather than generating lots of antibodies to trigger your immune system to do the same thing. So when you think about it, that's quite a remarkable result. Also known as BacTech. It's a sublingual bacterial immunotherapy designed to prevent recurrent respiratory infections. Okay, it reduces the frequency of recurrent respiratory infections, including lower respiratory tract infections. So it gets right down into your lungs, like bronchitis and pneumonia. And we've just talked about that. The key findings: studies showed 40 to 60% reduction in the number of infections in adults and children with the recurrent infections. So it's quite a difficult group of people to treat, but they seem to have quite a significant success rate. It did translate into reduced antibiotic use and reduced numbers of times when they had to visit hospital. So that's another measure of success. In chronic lung conditions such as COPD, asthma, and bronchiectasis, it has been tested and associated with fewer exacerbations and improved respiratory stability. So great news for this particular group. And as you can imagine, all it is a fluid containing dead bacterium, probably not dissimilar to something like yogurt, and very safe. Very nice that you don't need an injection. It's just a drop under your tongue for a few weeks. So all seems a bit too good to be true, but these are what the results are. Minimal side effects, as you can imagine. You're not sticking a needle into your arm. You're not going to get all that inflammation and the bit of pain and the swelling that you sometimes get. The occasional mild oral irritation, but that's it. It's taken under the tongue daily for 3 months, so a few months rather than weeks. And it triggers immunity and immune training. It appears to be an effective preventative strategy for patients with frequent and chronic respiratory infections, particularly those with underlying lung disease. So that's very interesting for this group because you'll obviously have at least one underlying lung disease. If this works in your group of patients, and there's no reason why it shouldn't, this should cut infections. It would cut your trips to hospital. It would cut your need for antibiotics, so you wouldn't have to worry about resistance developing and so on. This has got, from my viewpoint at the moment, this has got terrific potential. It works because the tissue under your tongue, the sublingual mucosa, is rich in the immune cells that you're trying to get at. It provides direct access to the mucosal immune system. And if you stimulate that with these dead bacteria, you end up strengthening the body's first line of defense against respiratory infection. It all seems so simple. But when you think about it, what that made me think of was this is reflective of if you're exposing yourself to a range of bacteria and you're getting this kind of response, it tends to suggest that you haven't been, especially in young babies, you haven't been exposed to these bacteria before. Why wouldn't you have been exposed to this type of bacteria before? Well, we're going back to the hygiene hypothesis that we're raising children in an environment that's too clean. If the environment was too dirty, maybe you'd be exposing them to low numbers of these pathogens, which would be triggering the same sort of immunity in our young babies. And we can restore that even in adults. So it's tremendously encouraging for a very simple way to protect ourselves against infection. And this group in particular. Okay, there's a bit of cell biology here. It's mucosa-associated lymphoid tissue, otherwise known as MALT, which is quite amusing. Things like dendritic cells, which are the very things that recognize and trigger your response to fungal infection. And these are the things that we suspect may not be working quite right in some aspergillosis patients. They capture antigens and present them to T cells, which triggers the trained immune response. So we don't really know what the mechanism or how they become more active and why does a macrophage suddenly become stronger and fitter and more able to eat more pathogens. We don't really understand what's causing that yet, as far as I can gather from this paper, but it does. It's one of those experiments where it's working, so let's not worry about how it's working until we've tried it on more people and more patients. Sublingual immunotherapy doesn't just create antibodies, which we've just talked about. It also teaches the innate immune cells, and those will be macrophages and something called NK cells, and NK stands for natural killer cells. So it does exactly what it says on the tin. It goes around killing pathogens. Okay, that's just repeating what I've said before. Clearly safer than injections. I mean, injections are not particularly risky, but a lot of people don't like that needle, don't like the little bit of pain. And of course, as we've learned, some people it causes quite a lot of pain after you've been vaccinated. So no injection alternative sounds very attractive. Very low risk of severe allergic response, seeing as it's processed slowly and locally under the tongue. So you don't have to worry about allergies either. And very, very broad spectrum. We don't know how broad spectrum it is yet. We've just these results only go back 5 years or so. So there's lots more work to be done. Done that one. Done that one. Oops. Sorry, I'm pushing the wrong button. Safe, broad spectrum. And the other nice thing about them is they're long lasting. This effect is long lasting. You take the drops under the tongue for 3 months. It can persist for a long time after that. So you can imagine that if you would just take a few drops of this for 3 months, every twice a year, something like that, it could reduce your risk of exacerbations and infection by quite a large amount, up to 50, 60, 70%. This, of course, is not yet here. It's not yet approved in the UK. It's really just starting to be tested in clinical trials. There was a trial in 2022 on COVID, but which has been stopped. But there's an ongoing trial in Spain on COPD, so very close to our area of interest, which is ongoing at the moment, and they're recruiting. Well, I think it's another trial they're recruiting for, actually. Here in the UK, the body that does this type of research is called the National Institute for Health Research, NIHR, has funded a balloon trial. It's just an acronym. I don't know what the balloon means, but that's just the title reduced into an acronym. It's assessing the effectiveness of this treatment in preventing lower respiratory tract infections in preterm infants, so a very highly vulnerable group. It's a full-on randomized, double-blind, placebo-controlled trial. So it's a very powerful trial in a very vulnerable class of patients. So if it shows effectiveness there, I'm sure we'll see pressure building for this to be approved for at least that purpose. Yeah, so it's coming. It's not quite here. It's got in its on its side, it's very low toxicity. It's easy to apply. There's very few risks. I can imagine if these trials, these studies go well, this type of treatment will start to become available within a few years. You can imagine the benefits to the NHS if we can prevent chest infections up to 50, 60, 70%. We can prevent people being admitted to hospital for all these things because of these oral vaccines, if you like, oral trainers. Difficult to know what to call them. That would be a huge cost saving in the NHS and a huge advantage to the patient population. So I feel it's a little bit like when we used to talk about biologic drugs. This was a revolutionary type of drug, and it is proven. I think this is possibly one of the next ones along the line that will affect this group of people. So thank you for Marcella for pointing it out to us so I could learn all about it and tell everyone about it. Someone has a hand up. Who was that? Belinda. Want to comment, Belinda? No?
Hiya.
Yes. Hiya.
I just wanted to say, sorry I was late, but also this is absolutely astonishing. This is
I'm astonished.
Yeah. It really is incredible to listen to and to hear it well explained. I'd love to know what BALLOON stands for, because that would be the words explaining I
can find out.
Yeah, but anyway, yes, thanks so much for explaining that.
You can see the potential in it, can't you?
Absolutely. And also the fact that this sort of work, it's all being done in Spain. This was all invented in Spain, is that right?
It has been tested. The group that's run it and the group that's currently doing it clinical trials is in Spain, in Madrid.
Okay. No, this could change things for millions of people, and
it certainly could.
It's so big. It's so big. So thank you so much for that. It's been. I'm just sitting here astonished.
It's the sort of thing we have to be a little bit reserved that we're getting overexcited about it.
Yeah.
But even if it's 20% effective, that's a big jump.
Yeah.
So we've started off on testing it on young babies, testing on more things. Research is starting up again after the pandemic, thank goodness. I haven't been able to find any other trials going on in the UK, but I think when this trial publishes, I think there'll be a whole group of people who will want to test it on the other groups.
So just to
notice it's not been tested on asthmatics yet, and that's the caveat.
Sorry, just that balloon stands for bacterial mucosal immunotherapy for prevention of lower respiratory tract infections in preterm born infants.
Well, there you
Hence
go.
the acronym. Okay, so very encouraging. I was very surprised to come across it. It was pointed out by a Portuguese member of one of our chat groups who's been offered that treatment for her exacerbations for ABPA, I think. A little bit, they must be doing it as a partner to the Madrid study. But I don't know specifically, but it'll be interesting to see. So we've got a test we've got a test group of one of our own to see how she gets on with this new treatment. And it's so simple. So yes, always when you're young, if you have children, feed them dirt for a while. Okay. Does everyone want a quick break while I think about it's probably worth doing. I've got a few little things to talk about. And then there's a whole other thing I could talk about if you want me to talk about it, or I can save that till next time. So let's have a sort of a 10-minute break and see you all again at 20 past. Right, how's everyone feeling? Up for another half an hour.
Quick question, Graham.
Go ahead.
I presume that that last thing you were the thing you were talking about, I presume it wouldn't be that expensive.
No.
I mean, apart from the research and the development, but the actual spray itself.
It's just probably saline and some deactivated bacteria, which would have been deactivated with heat, I would imagine.
Yeah,
it's not going to be.
Not going to be mega expensive.
There's no clever science. There's no complicated manufacturing. It's not even, doesn't even need to be that sterile. It's just going in your mouth, but it will be sterile, obviously. But
I'm a little bit profit for someone.
Well, absolutely. They'll probably, I don't know. I did find out the company behind it, which I think was Spanish. I can't remember now. But it's I've sort of filed it under maybe it's too good to be true, but let's just, time will tell.
Wasn't April Fool's, was it?
Sorry?
Wasn't April Fool's?
No, it wasn't. It's a published paper.
It will be more expensive for the Americans, but let's not go there.
No.
Yes, we have to export to them. Yeah. Mind you, 70% of medicines come from America, so yeah. Right, I can. Let's just go do a couple of little points I want to make, and then I can tell you all about autoimmune diseases and the treatments that they're going to cure those. Why didn't we think it was this easy years ago? Right, share. Have a look at that one. Okay, right. Just a couple of points. For us, most of you are probably aware of the British Lung Foundation Asthma UK joint website, which is for patients. That's just, which is here, Asthma and Lung UK. Very popular, 12 million views per year, which is a lot for this type of website. Covers all aspects of lung disease, so it has a section on aspergillosis, which we contributed to many years ago. I think I wrote the original one, but since then it's been rewritten by Chris Cosmidis, I think. So this is a great way we can reach out to everyone in the UK, and no doubt overseas as well. And they have a whole section on groups and support. And we have joined that group. We are an affiliated member or affiliated partner of that organization as of a couple of weeks ago. And the intention being to get our patient support out to as more people spread across the UK as much as possible, and also overseas increasingly. So that's good news. We have to sign a whole partnership agreement around that. It took a couple of months. But that should be able to help more people. And then there's the European Lung Foundation, who are an organization it's well worth knowing about. We have it covers, it's essentially the patient information arm of the biggest professional respiratory society in the world, the European Respiratory Society, the ERS. They fund this. And within this, our people are representing all different types of lung disease, including Lisa McNeil, currently represents aspergillosis on the, I think this is the board, something like that. I can't remember. But we can all get involved. So this is about World Aspergillosis Day, which ELF want to help us with. And And you can see some of the people involved here. The reason why you might want to join the Patient Awareness Group, PAG. We want to raise awareness of aspergillosis as a rare disease. Many people have never heard of it. Sorry, I'm coughing now. By working together, we hope to raise the profile and encourage more healthcare professionals and researchers to take an interest in aspergillosis. Because this group is strongly affiliated with the ERS, there are more than 100,000 professional members of that society. So this is a way we can reach out to those professionals and get them to understand more about aspergillosis. And if you feel so inclined, you can join with the work. I think there's about half a dozen people already doing this. With the hope of improving treatment and care in the future. We also want to connect with other patients across Europe to learn how we cope. Some members have not found any other aspergillosis patients in their countries, so joining a group means a lot. Okay, and you can find that at europeanlung.org. If you go to the Meet the ELF Aspergillosis page, PAG, it will tell you all about that group. You can join in with us if you want. We meet every few months and talk about what we can all get together to do and offer opinions on projects which will apply across Europe. It's well worth joining if you can. I appreciate with people who have chronic illness that that's not always an attractive option. And quite often people only spend a short amount of time on there, but if you feel you're up to it, I think it's well worth spending a little bit of energy over at the European Lung Foundation. I put this information onto Facebook periodically, so you can get it from there, or when we publish these recordings and YouTube on aspergillosis.org. Okay, so we've probably got time to do this. So autoimmune diseases. I don't know if you're aware of autoimmune diseases. There are all sorts of common diseases in the UK which are autoimmune. For example, rheumatoid arthritis, diabetes type 1, which leaves people vulnerable to aspergillosis. Multiple sclerosis itself is an autoimmune disease, and lupus is one of the nastier ones. And what this is your own immune system, back on that subject again, the immune system attacking your own body, your own organs. Why would your immune system attack your own body? Well, that's what it's doing, and that's what causes diabetes when it attacks the pancreas. When it attacks the nervous system, you get multiple sclerosis and so on and so on. So it's been a huge problem, untreatable, well, not quite untreatable. There's a long list of difficult, Addison's disease being one of them, autoimmune diseases, up to now, cystic fibrosis, and even asthma itself. Some types of asthma can be thought of as an autoimmune disease, or autoimmune-like. And a lot of these can increase vulnerability to aspergillosis. And some of you may have one or more of these things. Article was published in New Scientist, which I link to at the top of that slide, which describes a little bit what an autoimmune disease is. And autoimmune diseases occur when the immune system mistakenly attacks the body's own cells instead of treating them like, instead of attacking harmful invaders that it would normally be expected to attack, like bacteria and viruses. The exact cause isn't fully understood, which is why it's been so hard to try and find a cure. But a combination of genetic causes, environmental causes, and immune system factors is believed to trigger autoimmune. You can live a fairly normal life, and then suddenly one of these things can trigger inside you, and things like MS, for example. And suddenly you've got this progressive disease that's very difficult to treat. I think I shouldn't have stopped. I've started coughing now. So, what's behind all this? So, like we were just talking earlier on, we were talking about our, I forgot the name of it now. The primary immune part of our system. There's also the adaptive part. The adaptive part is the part that produces the antibodies that we talked about earlier on. It's powered by things called B cells and T cells. And these are some of our most trusted allies when we're fighting bacteria, viruses, dirt entering wounds, etc. They recognize signal molecules on the surface of bacteria and viruses and use them to identify whether it is friend or foe. So at some point it's learned that if it detects a molecule that's present on the surface of a bacterium, that's an enemy and it attacks and kills it. And the same with viruses and so on. If it is a foe, it is destroyed, because what happens is the antibodies cause B cells to bind. The B cells reduce things called cytokines that attracts in all the macrophages, and they will kill the invading pathogen, just like we described previously. However, given that your body is made of very similar stuff compared to something like a bacterium or a virus, they're made out of proteins and fats and carbohydrate, and our bodies are full of exactly the same stuff. How does this work? It must be very good at tagging what is for destruction and what is to be left alone. In other words, not works, it must be very good at telling the difference between self, us, and non-self, the pathogens. They learn that lesson, not surprisingly, when we're very young. The T cells tend to learn it in our thymus, and that's what your thymus is for exposing T cells to a whole range of antigens. B cells also participate in this, but they do that in bone marrow. They're exposed to self. They're exposed to self, and if they react too strongly to self, those cells are eliminated. So we produce a whole variety of these cells, and we choose the ones that don't eliminate self, and that's how they are selected to not harm us. Clearly, something is going wrong. 95 to 98% of T cells that are put through this process are killed because they are reacting against self, because you can imagine the thing they most come into contact with is self rather than non-self. It's clearly a problem with this system whereby they distinguish between self and not self that causes autoimmune diseases, because as soon as you fail to distinguish between you and the pathogen and you start attacking you, then you've got an autoimmune disease. A good example is lupus, and I know there's a few people that are in our support groups who have lupus, because this is one of the autoimmune diseases that will leave you vulnerable to aspergillosis. It's potentially life-threatening and damages skin, joints, heart, lungs, kidney, and brain. And it's caused by dysfunctional B cells that are producing antibodies against the person's own DNA. And of course, your DNA is in every single cell in your body, so this is a serious problem. Similar with type 1 diabetes, T cells start to attack the insulin-producing cells in the pancreas by mistake. Okay, what can we do about this problem? At the moment, the main treatments are to dampen down the activity of your immune system. And we're all familiar with the use of the drug prednisolone, also methotrexate and various inhibitors. They work. But as we all are aware, they tend to come with lots of side effects that we don't like, are very uncomfortable, and include vulnerability to infection. It would be much better if we could eliminate and retrain these defective immune cells. And that has been the goal in people trying to treat autoimmune diseases for decades. So what can we do about it? We seem to be living through an era, a golden era of new medical treatments, and these are some of them. You may have heard of CAR T cell therapy in association with treating cancer. Some cancers, it's producing remarkable success at treating some cancers. It's even being used against aspergillosis specifically, which is very encouraging. I must talk about that in more detail. I think I talked about it a while ago. But this is a different way to use the same system, the same tools to produce, to eliminate autoimmune disease. We can take some of the patient's T cells, and we've seen that in some autoimmune disease, it's the T cells that are going wrong. They've forgotten the difference between self and non-self. And we can effectively reprogram them to attack B cells. And B cells are the other set of cells that are making mistakes and attacking your own body. So they can take your own T cells, they can reprogram them, give them back to you, and those T cells will now attack the bad B cells. And that means all the B cells that are causing the autoimmune problems, as well as all the ones that aren't, because there'll be a mixture in your body. Not surprisingly, this is hazardous at first because it's a bit like getting a bone marrow transplant. For a while, you've got fewer B cells, and thus you are vulnerable to infection. But the B cells grow back, and importantly, in some people, only the good B cells grow back. We don't really know why that happens, but it does in some patients. The defective B cells don't reappear. There's a theory that it's harder to produce defective B cells that have been caused by a rare mistake, and if you eliminate the cells that originate from that rare mistake, it's very rare for the mistake to happen again, so you can actually cure someone of this B cell autoimmune disease, and that works. I'm not sure if I've done small trials have been done. 5 patients with lupus were treated. This is probably 10 years ago. And all 5 were able to stop medication for lupus. Some of the patients are still lupus free after 4 years and have only had 1 round of treatment. So if 1 round of this has kept lupus patients free for at least 4 years, which is might not sound that incredible, but that's quite an incredible result. What is the drawback? Well, let's talk about, there's the drawback at the bottom. It takes a long, so that's just what I've said. It's a long time to build up enough lupus cells to cause problems. So if you eliminate everything and just the good ones will grow back. There are clinical trials currently operating in University College London on this. So early days, but phase 1. But the problem with this approach is the treatment has the potential to be highly effective. It costs about £500,000 per patient, and that's the problem. It's a very expensive, intensive process, but it does work. However, it would be better if we could find something a bit cheaper than £500,000 each. So, are there alternatives? Something called reprogrammed T cells is an alternative. This is where it's the T cells that are defective. The T cell has learned to attack a specific self-antigen. So that's where it's made the mistake and turned itself into something that's attacking you. You can produce these small, don't know what you call, they're not beads, they're much smaller than that, nanoparticles cover them in the antigen that the T cell is recognizing as self. And if you give the patient a whole lot of these nanoparticles, you drown out the defective T cells. They are overwhelmed with that antigen. So it's pretty easy. You just make nanoparticles covered in a single protein, give the patient that. Something remarkable happens. The defective damaging T cells become a different type of T cells, one that suppresses and protects self, reducing the disease. So that it becomes a very effective treatment for those types of autoimmune disease. Again, we're at phase one trial stage, but that's showing a huge amount of promise at preventing that type of autoimmune. So we're talking about liver autoimmune, type 1 diabetes, inflammatory bowel disease, rheumatoid arthritis, and multiple sclerosis all come under this definition of autoimmune disease. And not surprisingly, work is underway to test this treatment, which is far cheaper. I would imagine just probably less than a tenth as expensive as CAR T, probably a lot less than 10%. So that's one alternative. Then there's something called inverse vaccines. Unlike normal vaccines, which teach the immune system to recognize and attack an antigen associated with a particular pathogen, so a very specific attack, an inverse vaccine does the opposite. It erases the immune system's memory of a self-antigen. So your immune system is attacking this antigen that is causing these problem that's causing the autoimmune disease. This technique, it's kind of a bit vague. If you remember, I said the training of T and B cells happens in the thymus and in bone marrow. It also goes on in the liver to some extent, but if it goes on in the liver, those antigen recognition molecules, those T and B cells, I should have said, if they're trained in the liver, they tend to dampen down the severity of the immune response, reduce inflammation, rather like the Novosims do. And this is probably even cheaper because all you do is you attach the self-antigen you want to work with to a polymer. The polymer sticks it in the liver. It can't leave the liver. And once it's in there, it trains the T cells to recognize and now tolerate the antigen, reducing or removing the autoimmune response. In animal cells with mice with multiple sclerosis were successfully treated using this technique. Again, we're in animal cells, we're not even in clinical trials, so this is a few years away yet, but all three are revolutions in the treatment of autoimmune disease, and they all work. Phase 2 clinical trial in inverse vaccines is currently being carried out in people with celiac disease. I'm sure that'll be good news to people with celiac. And celiac disease is an autoimmune condition associated with an intolerance to gluten. A lot of us follow gluten-free diets because we are intolerant of gluten, but people with celiac disease are really severely intolerant of gluten, which is why this treatment is being carried out. And also in a phase 1 safety trial, so a phase 1 trial means you're just testing it for toxicity in people. So the next stage is to actually assess whether it works in those people. With people with MS, which would be amazing to actually be able to suppress MS after all these years. So we live in encouraging times. Okay, Belinda.
Hi. Yet again, thank you for that. You are giving people hope. This is just very well explained, and thank you. I'm particularly interested. Yeah, it was all down to you. I'm particularly interested in that because my best friend has a rare autoimmune disease that the NHS don't really recognise, even though it's recognised in the rest of the world, to do with MCAS cells. Her body is basically killing her, and I don't think she's got very long left. And it's so upsetting because she knows more about it than her own GPs, and she's had to pay out so much private of her own money for specialists to help her. And because that makes you so depressed, she's now paying out for therapy. So all of these will hopefully feed through to all, and not just the very better known autoimmune diseases. But there was a series on TV about diagnosing rare conditions. I can't remember, it was about a year ago, and someone was actually diagnosed with an MCAS issue, and it was the